Hello everyone, my topic for today is keratitis. So I'll be starting with keratitis. So keratitis can be classified into two categories. It can be an infectious category or it can be a non-infectious category. Okay. Now this infectious category can further be classified into suppurative and non-suppurative. Today mainly I'll focus on this infectious category. So the non-infectious keratitis. Now as we all know that suppurative means pus. Okay. So those organisms which lead to formation of pus will be suppurative. These are mainly bacteria and fungi, and the ones which do not cause pus or the non-suppurative categories will be virus and parasites. Okay. Now these parasites can either be protozoa or they can be helminths. Helminths. Okay. So I'll start first with bacterial keratitis. So, bacterial keratitis is the most common kind of keratitis. Okay. So first I'll tell you about the causative mechanism of bacterial keratitis or bacterial corneal ulcer. Okay. So all of these which I tell you will be MCQs from now on. The first organism is Staphylococcus aureus. Okay. So this is the most common cause of bacterial keratitis worldwide. Okay. However, in India, the most common cause is Streptococcus pneumoniae. Okay. The most common cause in India. Another peculiar feature about the Streptococcus pneumoniae is that it causes ulcus serpens. This is the name of the ulcer which it causes. This is an MCQ again. Okay. So why is this called ulcus serpens? Because of its serpiginous spread. Okay. Serpiginous spread. That means like a serpent or a snake. So what basically happens is, if suppose this is my cornea and this is the ulcer. So it's a rapidly growing kind of ulcer. The organism is very virulent. So it will keep growing in a serpiginous fashion at the trailing end, but at the exact opposite end there will be cicatrization simultaneously. Okay. So this is why it is called ulcus serpens. Okay. And this is the zone of cicatrization. Usually these ulcers are central first to appear and then they keep on spreading towards the periphery. Okay. Now also the kind of ulcer which is caused by this Streptococcus pneumoniae is also called hypopyon ulcer. Okay. This is the name of the ulcer it causes. Please don't get confused. Other organisms will also cause hypopyon, but the name of the ulcer which is caused by Streptococcus pneumoniae is hypopyon ulcer. Okay. Now moving on to the next organism. The next organism is a Pseudomonas aeruginosa. Okay. So Pseudomonas aeruginosa also is a very virulent organism and it is very notorious for perforation. Okay. So Pseudomonas aeruginosa, pyocynia is responsible for causing ulceration as early as 48 to 72 hours after the attack of the bacteria. Okay, so this is also a question. Very notorious to cause perforation of the ulcer. The next organisms are Neisseria gonorrhoeae, Neisseria meningitidis and Corynebacterium diphtheriae. So these three organisms have the capability of penetrating an intact epithelium. So there should be no epithelial defect also, and these organisms will be able to invade the cornea. Okay. So this is also a question. Neisseria gonorrhoeae, Neisseria meningitis and Corynebacterium diphtheriae will be able to penetrate an intact epithelium. Okay. So all these are questions. Now I'll tell you about the risk factors. Okay. Quickly I'll tell you about the risk factors. So what can be the risk factors? First of all, as we know that our cornea has 5 layers. Okay. The first layer is epithelium. Okay. The second layer is Bowman's membrane. The third is stroma. The fourth is Descemet's membrane. And the fifth is endothelium. Okay. There's also a new layer which was invented by Harminder Singh Dua, which is called Dua's layer. Okay, this is the 6th layer. Okay, this also can come with an MCQ. Now I'll tell you a little bit about the peculiarities of these layers. So this epithelium, this needs to be breached for an infection to enter inside. Okay. This Bowman's membrane is very peculiar that it is very resistant to infection, but once it has been destroyed, it cannot be regenerated. Okay, so we cannot get it back. The stroma also, after getting destroyed, it heals, but the healing is in form of scarring. Okay, so this stroma will scar because the regular arrangement of the collagen cannot be gained back. That is why after healing, the stroma will go for scarring and lead to formation of scar tissues. Okay. Another important thing about this corneal structure is this Descemet membrane. This Descemet membrane is also very resistant to the spread of infection, but this is able to regenerate. Okay, this can regenerate, and this is able to withstand a lot of infection and a lot of pressure also. And this will, but however, once it's destroyed, it will be able to regenerate. This endothelium is a single-layered structure. And obviously once it's lost, it can never be regenerated back. Okay. So the understanding of these 5 layers of the cornea is going to help us to understand the pathogenesis. So I was telling you about the risk factors. So the first risk factor is that there should be a trauma so that my epithelium is breached. Okay. So if the epithelium is breached, the infection will be able to enter inside the cornea. So the first thing is trauma. Okay. Okay. Alcoholic patients, age of the patients, okay. Use of steroids, dry eye, and trichiasis, and entropion. Okay. These are the risk factors because the lashes will keep on rubbing on the surface of the cornea and will lead to trauma. That is why these are a few risk factors, okay, for the better understanding. Now, so how this ulcer will spread? What is basically the pathogenesis of this ulcer? So suppose we have this epithelium of the cornea. So once this epithelium is breached, whatever infection is there, it will be able to enter inside the surface of the cornea. Okay, so once it is entered, there will be the first stage of infiltration. Okay, first stage, after the bacteria has invaded, there will be a stage of infiltration. So from the body, inflammatory cells will come and they will try to fight against the infection. So first is my stage of infiltration, where the inflammatory cells are going to come from the vasculature, from the limbus. Okay. The second is stage of ulceration. Okay. So in this stage of ulceration, progressively these inflammatory cells and the toxins which are released by the bacteria are going to continuously macerate the corneal tissue and are progressively going to form an ulcer. So that is why this is called a stage of ulceration, or it is also called a progressive stage, where the ulcer keeps on progressing. Okay. Now my third stage is the stage of regression, or it's also called the stage of healing. So suppose this is my cornea and this is where my ulcer is. Okay. So because of the defense mechanism of the body, there will be a demarcation line which is formed between the ulcerated and the healthy cornea. So these basically consist of inflammatory cells and they constitute actually a line of defense for the ulcer to spread. And because of this, the ulcer will then start healing. But one problem with this healing of corneal ulcer is that the original structure of the cornea cannot be regenerated. So that is why it will enter into a stage of cicatrization. Okay. So cicatrix will be formed. So what will happen here, that the ulcer will start healing, the epithelium will start regenerating, but what will happen, this Bowman's membrane cannot be regained back, so this Bowman's membrane is missing, and this stroma, it will get arranged haphazardly. Okay, so here is what will happen is that a scar will form. Okay, because of the cicatrization. So basically the fibroblasts are going to form the scar tissue. Okay, so the cornea will not be able to regenerate its normal anatomy again after the ulcer. So this is the pathogenesis of corneal ulcer. Okay. Now what are the signs and symptoms? The symptoms of this corneal ulcer will be pain, redness, photophobia and watering. Okay, and these features are common to any kind of ulcer that will affect the cornea. So any kind of ulcer, this pain, redness, photophobia and watering will be there. Okay, now coming to signs. So obviously because this is a purulent kind of ulcer, a whitish to yellowish ulcer will be visible. And another very important thing which happens here is the hypopion. Okay, so hypopion basically are cells which are released by the body's defense mechanism only. Okay, so what will happen? These toxins which are released by the bacteria will reach into the anterior chamber. Okay, and from the anterior chamber some cells are going to get released like neutrophils. Okay, and because of the effect of gravity and because of the posture of the patient, these cells are going to accumulate. Okay, and a hypopion will be formed. The important thing about this hypopion is that in bacterial corneal ulcer, this hypopion is sterile. Okay, because there should be a breach of the epithelium for the there should be a breach for actually the organisms to enter inside the anterior chamber. Okay, but since only the toxins are diffusing inside the anterior chamber, this hypopion is actually sterile. Okay, this is one question, that hypopion is in bacterial corneal ulcer is sterile and also it is mobile. Okay, so if the patient changes his posture, this hypopion also will change its position according to the posture of the patient. Okay, so this is important. Another signs of the patient obviously will be there will be circumcorneal congestion. Okay, there will be redness and there will be corneal edema. So these are certain signs. The most important out of which is my hypopion, which I already told you. So a hypopion in a bacterial corneal ulcer is sterile. Okay. Just so that you don't forget, I will tell you something, that hypopion in case of a fungal ulcer, however, is non-sterile. Okay, because the fungal hyphae are actually able to invade the corneal structure first, and also it is non-mobile. Why it is non-mobile? Because of a lot of fibrin, this hypopion gets consolidated and it will not move the way it moves in case of a bacterial corneal ulcer. Okay. So these are the signs and symptoms in a bacterial corneal ulcer. So when a patient comes to you with corneal ulcer, so what do? Obviously we have to manage it. So how do we manage a bacterial corneal ulcer? The first one is investigations. The first thing which we do will be certain investigations. So what are the investigations we do when a patient comes to us? The first thing is that we have to do a routine complete blood count. We have to do a differential count. We have to assess the blood sugars. we have to do the liver function test. Why liver function test, I'll come and tell you later. And you have to do a routine urine microscopy. Okay. So these are the investigations you need to do for every patient. Okay. When a patient comes to you with corneal ulcer. Now specifically to cornea, what do you need to do? You need to do, if this is my ulcer here, I need to do scraping. So what will I do? I will take a Kimura spatula. Okay. This is also an MCQ, that corneal scraping is done with the help of a Kimura spatula or a 20 gauge hypodermic needle. Okay. So with these instruments, we scrape a little bit of the margin of the corneal ulcer and a little bit of the base of the corneal ulcer. Okay. So we collect this sample, and then these samples are subjected to gram stain, Giemsa staining, 10% KOH, okay, and we will do blood culture also, and we will also plate it into Sabot's dextrose agar for the growth of fungi. Okay, so these are the certain things we will do. Okay, so one thing I must tell you over here is that when you are actually sending for the microbiology, you would like to investigate all the organisms together. Okay, whether it's a bacteria, or you want to know about fungi, or want to know about acanthamoeba, because you cannot look at the ulcer and you can definitely every time tell that which kind of ulcer is that. So when you want to investigate all the organisms together. So this microbiological investigation for all kinds of ulcers will be the same, irrespective of what is the etiology of the ulcer. Okay. So after you've done this basic investigation, you have to start the patient on a specific treatment for corneal ulcer. That is, you have to start the patient with antibiotics. Okay, if you're suspecting that it is a bacterial corneal ulcer. So what are the antibiotics you can go for? The first one is you have to go for fortified antibiotics. Okay. So what are these fortified? Fortified in simple terms, you might say that these are high dose, extra dose antibiotics. Okay. Because the cornea is an avascular structure and you have to give an extra dose of antibiotics, because usually no defense mechanism of the body is going to work because it's an avascular structure. Some amount is mounted by the body, but it's not sufficient. So that's why you have to give an extra dose of antibiotics for this corneal ulcer. So that is why you have to give fortified antibiotics. So what are these fortified antibiotics? The first one is cefazolin, percentage 5% cefazolin. You have to give tobramycin, 1.3%. and you have to give vancomycin. So any of these antibiotics you can give, because these are all broad spectrum antibiotics. And other antibiotics which you can give are non-fortified simple fluoroquinolones. But these antibiotics are not much used and are not very effective because of the widespread resistance. Okay. So this is a specific thing which you are going to do for a corneal ulcer. These are specific fortified antibiotics which you are going to start. Now there is something, because the patient has a lot of symptoms also, so you also have to give some non-specific treatment for this patient. Okay, so what are the non-specific things which you are going to do for this patient? You have to curb the pain of the patient. So for pain, you have to give certain analgesics. Okay, and another very effective thing for pain relief is cycloplegics. Okay, cycloplegics are given. So how these cycloplegics will help in pain? They are going to reduce the ciliary spasm. Okay, and that is how they are going to reduce the amount of pain. Okay, also they are going to cause vasodilation. Okay, so this will increase the blood supply, and because of that, an immune reaction by the body itself can be mounted. That is why vasodilation. Also another thing which they will do is that they will prevent the formation of synechiae. Okay, so these are the things why cycloplegics are given. So what cycloplegics are given? You can give atropine, you can give homide, you can give cyclopentonate. Okay, these are the symptomatic management that you will give. Okay. So sometimes what happens as a complication of corneal ulcer, because of the inflammatory reaction, the angle of the anterior chamber might get occluded. So when it is occluded, the intraocular pressure will be raised. So because of that, you will have to give anti-glaucoma medications also. Okay. So these anti-glaucoma medications also you have to give. Other than that, you have to ask the patient to rest. You will give dark goggles to the patient to prevent photophobia, and also you will ask the patient to have a nutritious diet so that the body is able to fight infections in general. Okay. Now, to finish with corneal ulcer, I'll tell you some amount of complications that might happen after a corneal ulcer. So if this corneal ulcer goes untreated, what will happen? So if suppose this is the depth of the cornea, this ulcer will go on increasing till it reaches my Descemet membrane. So this Descemet membrane is very resilient, it is very resistant, so this will try to contain the infection. Okay, but this whole stroma, which is 90% of this cornea, is almost gone. So this Descemet membrane is not that strong to contain the infection. So what will happen? Because of the intraocular pressure which is there in anterior chamber, this Descemet membrane will actually bulge out. Okay, and this will form a desmetocele. Okay, desmetocele. Okay, so what will happen? It will be a bulged cornea, and there will be a ring surrounding it. Okay, so this is what is a desmetocele. Now suppose if the infection is not controlled at this stage also, and the patient strains, cuffs, maybe applies pressure during stool, so this Descemet membrane also will go, and the person actually has landed up into a perforation. So the cornea is actually perforated. Okay, so as soon as the cornea perforates, what will happen? The iris which was behind, because of the perforation, this is also going to come and plug the corneal ulcer. So there will be a prolapse of iris. Okay. When the iris prolapses, the lens which is also behind will try to come forward, and if it's a large perforation, sometimes what will happen? The lens will also come out. Okay. And because of that, the structures which are behind also, they will go into vitreous hemorrhage, or there will be a retinal detachment, which also might happen. So if the ulcer is not treated, stage by stage we can go into all this. Also, the ulcer, when it comes in contact with the lens, it will lead to formation of an anterior capsular cataract. Okay, and ultimately the patient will go into endophthalmitis and panophthalmitis. Okay, so all these complications if the infection is not controlled. Okay, another complication which I already told you, even if it is treated at a later stage, the cornea will ultimately go into scarring because the original anatomy cannot be retained back. Okay, so this is all about corneal ulcer. Now I will talk to you about fungal ulcer. Okay, this is also a purulent category of ulcer. The fungal corneal ulcer. So most of the things are similar. Okay, in a fungal corneal ulcer, the signs, the symptoms of the patient, presentation to a lot of extent. Okay, so first again I'll tell you the causative organisms of a fungal corneal ulcer. The most common organism is Aspergillus. Okay, Aspergillus is the most common organism. Also it is caused by Candida and another filamentous fungi which is called Fusarium. Okay, so these are the organisms which are responsible mainly for fungal corneal ulcer. Now, this fungal corneal ulcer is very, very typical if it occurs after a vegetable matter injury. So suppose if there is a thorn prick, or if there is an agricultural matter prick So because of those things, a fungal corneal ulcer. So if there's a vegetable matter injury, most likely the kind of ulcer will be a fungal ulcer. So it's very important when you ask history of the patient if it's a vegetable matter injury, that if that is the nature of trauma. So certain peculiarities are there about this fungal corneal ulcer which will help you to distinguish clinically if it's a fungal ulcer. So it's a fluffy kind of ulcer. Okay, first thing, it will be a fluffy kind of an ulcer, and the margins of the ulcer will actually be filamentous, okay, or feathery, you can say. So this is the ulcer. The margins of the ulcer are quite feathery. Okay. If again now this is the ulcer, there will be some satellite lesions, okay, around the ulcer. So why satellite? Because this is the main body and some satellite bodies are actually revolving around it. Not literally revolving, but they are present around it. So some satellite lesions will be there. Okay. And another thing will be, there is something called an immune ring. So because of the defense mechanism of the body, there will be an immune ring, which is also called the immune ring of Wesley. So please note down that this is not a characteristic of fungal corneal ulcer. An immune ring can be seen in case of fungal corneal ulcer, but it also can be seen in other kinds of corneal ulcer. And about the hypopion, I already told you. The hypopion is non-sterile because the hyphae will penetrate, and it is non-mobile. Also, it's said that, and it actually is also, that in a fungal corneal ulcer, the signs are much more than the symptoms. So the patient is not very symptomatic, is not under that much pain, but still the signs will be very, very grave in a fungal corneal ulcer. Okay, so in examination you will have a lot of findings, but the patient may not actually be that symptomatic. Okay. Now, how are you going to treat this fungal ulcer? The non-specific therapy is going to be the same. Okay, but specifically antifungals, what you have to do? What you have to give? You can give topical in form of natamycin. Okay, so this natamycin 5%, what this does is, this is an antifungal also, but also this has a role that if suppose here is my ulcer, this will actually go and form a layer around it. Okay, and this will try to, help in faster healing of the ulcer by forming a layer on top of the ulcer. Okay, natamycin, amphotericin B drops can also be given. Okay, and itraconazole, voriconazole are also available in drop forms which you can give. Okay, another thing which you must remember, I told you that why do we do liver function test? Why do we do liver function test? Because sometimes when the ulcer is progressing, we are supposed to start systemic antifungal for these patients. And most of these systemic antifungal patients are known to derange your liver function. That is why you should previously, only for your record purpose, you should do a liver function test and you should be ready. Okay, that you are not further deranging the liver function of the patient by giving systemic antifungals. So that is why liver function test is a compulsory thing when you send for investigations. Okay, so these are the things which you can do for a fungal corneal ulcer. I already told you that when you do investigation, you have to do a 10% KOH also. A 10% KOH is quite effective to look at the fungal hypha. Okay, and also culture wise you have to do sabot dextrose agar. Okay, this is also a question. Okay, so you have to do sabot dextrose agar also for culture of fungi. Okay, so these are the specific things which you're going to do. So in the second part of my video, I will be talking about the non-suppurative types, and the non-suppurative types will be virus and acanthamoeba. I'll talk to you about these in my next video. Okay, thank you so much.